So tonight we are going over Chapter 22, Immunologic Emergencies. And this is going to be the same thing that we've been doing where we have our EMTs and our advanced EMTs together at the same time. So we're just going to go over these lectures and talk about how we're going to handle immunological emergencies, okay? At least 1,500 Americans die annually of allergic reactions. It sounds like that's a really small number, but it's really not. Allergy-related emergencies can involve our acute airway obstruction and then our cardiovascular collapse. And we'll talk more about those in just a minute. So when you're going on these scenes and you have somebody that says, hey, I'm deathly allergic to a bee sting or I'm deathly allergic to peanuts, be aware that they probably already have epinephrine, an EpiPen, if you will, and they're pretty quick to pull those out. But every now and then you will have to help them with it, okay? So we're also going to be able to distinguish between the body's usual response to an allergen and an allergic reaction. Okay, so let's just review our anatomy. And you guys know I love going into anatomy, but tonight I'm going to keep it just at the slides level. So our immune system protects the human body from foreign substances and organisms. What that means is if it's something that's not within the body already, and that's going to be like sometimes it's bacteria, sometimes it's virus, sometimes it is a venom, things of that nature. Our immune system is going to say, hey, that's not cool. I got to take care of this. Okay. And so we have what's called cellular immunity. And this is where we have our specialized T cells that attack and destroy all of our invaders. And then you have your humoral immunity. This one is where you have lymphocytes that produce antibodies. And those just go into our plasma and lymph just to wage war against our invading organisms. So there are just 5 general categories of our allergens. And these are just things that people can be allergic to, and you can come up with your own stuff there on what's what. But some of these people that have, especially bee stings and foods, they can die from these foreign bodies or foreign substances when they So table 22-1 is going to show you a lot of those, okay? When we have our first encounter or our first pass, you'll hear it's called first pass. That is going to be where the body is, oh, okay, I don't know what this is. I'm just going to scan it. I'm going to know what it is. I don't like it, but I'm not really going to have a huge response. What it's doing is it's like a scanner, if you will, and it takes a really good picture of it. And it says, okay, if I see you again, I'm going to whip up on you. That's what it's doing. It's getting a good picture. It's getting a wanted poster ready. And it's saying, if you enter my body again, it's not going to be nice. Okay, that's part of our primary response. And the body just develops a sensitivity through that primary response. Like I'm saying, hey, I see you. I don't like you. So what happens here is you have your basophils and your mast cells they open up and they say, okay, the macrophages, they come up, they engulf whatever that invader is, and they determine if this is going to be allowed in the body or if it's not. And if the body is, hey, I really don't know if this is an invader or not, that's when we have that scanner, so to speak, of it records what this is, all right? That wanted cell or that wanted poster is made. So now our immunological cells, they're going to design some proteins to match these substances. And these are going to be our antibodies that match up with the antigen and that inactivates it. Your body will develop sensitivity through our primary response, the ability to recognize the foreigner next time it's encountered. The body places specific antibodies on basophils and the mast cells, like I was saying before. And so they're mast cells on patrol through connective tissue, bronchi, GI mucosa, and other vulnerable border areas, okay? Deborah, we're on chapter 22. The other chapter was recorded, and you were supposed to watch a video on that. Essentially, at the end of all of this, or I'll say back in okay, Deborah, I'm just confused. I tell you what, I'm going to go ahead and continue to teach and you just catch up on this one, okay? Contains granules filled with powerful substances to fight invading forces of antigens. And the granules get injected from our mast cells and detonated if an antigen invades the body. So what does that mean? Hey, there's something here, we don't like it. And then you have degranulated degranulation. And this is where the granules are just going to burst. And when that happens, we have an immense immune response, more so than what you would have like with a normal one. And that's the whole point. So when you think about degranulation, you think about the granules or maybe like a grenade bursting, and it's launching such a massive immune response. And this is where you have these chemical mediators causing that systemic effect. And this is where we have our anaphylaxis. So it's a whole lot involved there. And you guys can look at this picture. I'm sure some of y'all were already looking at the picture as I was going over this. So we have acquired immunity. We have natural immunity. And of course, our acquired immunity is where we get a vaccine. And then obviously, natural immunity, that's when our antibodies are produced from invading things. We just get this full body experience, and then we're good. Like varicella, every single one of you had to have a varicella titer. That is chicken pox. For those of you who don't know, I'm sure most of you probably do by now, because you're like, what the heck is varicella? That's what it is. Chicken pox has actually been almost eradicated at this point, which is crazy, because I remember being a kid and, oh, Shelly has a chicken pox. Oh, little Patricia and little Timmy are going to go over and play with Shelly today. And I didn't understand what it was for, but it was because, hey, it's during the summer and you don't have to miss a week of school. And so what our parents were doing was giving us natural immunity. It actually sounds almost like child abuse, but sorry. So continuing down with immune system becomes hypersensitive to one or more substances during abnormal reactions. Yes, Jared, chickenpox parties. That's exactly what it was. The body is going to develop our antibodies in response to our vaccines, and it's going to neutralize the invading diseases. And so this is just a controlled way that our body develops all of these antibodies. If an actual virus does enter our body afterwards, the virus is immediately identified, antibodies are immediately produced to kill it. And so then our secondary response is more of an intense response, because it's like, hey, I've already seen you, I didn't like you, I made a wanted poster, we're done. Acquired immunity, you have that administration of that vaccine. It allows that body to produce our antibodies. And we've heard a lot about vaccines, especially in the past few years. As people, they may be unaware that they even have the virus in their body. It's just happening. They may even run like a low-grade fever and not realize they're really sick. Their body just may need a little extra, like a nap, okay? Natural immunity, the body experiences the full immune response with all of its effects and diseases. And by definition, allergic reaction is a reaction by the body's immune system that occurs when a person has previously exposed or sensitized to a substance or allergen, which I hope I've explained in this way. Immunology is not necessarily the most exciting, but once you understand that, hey, when allergen comes into your body, it gets scanned on that first pass. Everything gets a first pass, everything. And then it's that second pass is there going to be a hypersensitive reaction to it, or is there just going to be an allergic reaction? So allergic reaction is mild, it's localized. Yeah, there's a systemic reaction, but it's not as bad. It does occur throughout the body. You may have some wheals and things of that nature. You may have some widespread itching, but an allergic reaction is still mild. And then you have a hypersensitivity. And this is when there's that exaggerated or inappropriate allergic response. Remember, we talked about the degranulization, where the granules are exploding all over the place. Pardon me. Like all the pollen that we get growing and everywhere right now. I'm ready to scratch my mouth. Yes, Lindsay, that's exactly right. So you just have a mild allergic reaction to that. But hypersensitivity would mean you couldn't even walk outside. Anaphylactic events can sometimes be mistaken for heart attacks, some heat strokes, and other conditions, but you should definitely know the difference. And you have rhinitis, which is a runny nose, asthma, atopic dermatitis, and increase in potential for anaphylactic reactions when you see diseases related to allergies, okay? So anaphylaxis is that response mediated by the IgE antibody, and anaphylactoid reaction is a response that does not involve the IgE antibody mediation. And that may occur without the patient even being previously exposed to the offending agent. Okay, so pathologic response, we have mast cells recognize invading substances and release chemical mediators. Your histamine, that's, you guys have heard of Benadryl. That's an antihistamine. That's the opposite of what histamine does. Okay. So antihistamine causes blood vessels in the local area to dilate and the capillaries to leak. So if we are trying to stop that, we'll give Benadryl, right? See where we're going here. We don't want the blood vessels to dilate. We don't want the capillaries to leak. But I want you to keep thinking right there. Let's go back to that one line. Capillaries to leak. I want you to think about, we're going to talk about anaphylaxis in a little bit. And anaphylaxis causes widespread dilation and capillary leakage. And what happens when we don't have enough blood in our body? It's not inside the veins, it's not inside the vessels, and therefore we lack oxygenation, we go into shock, right? So think about that. They're leaking blood. That's what they're leaking. They're leaking all of it. It's not just, it's leaking into your body, so to speak, okay? Leukotrienes are more powerful than our histamines, and they cause additional dilation and leaking. So that one is even worse, so to speak. You have your white blood cells that help engulf and destroy. Those are your macrophages and things of that nature. And then your platelets are going to begin to clot and clump together. And that's also called aggregate or aggregation. Okay. In most cases, this overreaction to harmless invaders is restricted to the local area being invaded, and you're going to see like big red spots and things of that nature, like right here. So in anaphylaxis, you have chemical mediators that are released, and our initial effect is going to be seen with obviously the release of that histamine. Your leukotrienes will come in later, but the secondary effects follows a few hours later. Anaphylaxis, everybody thinks, oh my gosh, you got stung by a bee, EpiPen now, stat, because we watch the movies a lot. But anaphylaxis, you got to think about it. With the first pass, it looks at you and it says, hey, I don't like you. My second time, hey, didn't I tell you to get out of here? All right, come on, let me beat you up a little bit, but I'm going to take my time beating you up. Oh, you came back in here a third time? Oh, I'm going to beat you up, but it's going to take a little less time this time. Okay. Fourth time gets a little less. Fifth time, a little less. Sixth time, and it could be the sixth time where you're like, your airway is closing up. Okay. Oh, sorry, Chris, you're right. It is plasma. Y'all forgive me. I'm running 101-degree temperature and I just took 8 milligrams of Zofran. I'm trying, okay? The immediate vasodilation is, you're going to see the flushed skin, hypotension. You're going to see swelling. No one heard it, Christopher. You're even going to have angioedema. And that's going to, and even edema, as you see in this picture, you have that urticaria, you have wheals, you're going to have your airway constriction, increased fluid in your airway. And essentially what happens when all of anaphylaxis occurs, your body says, nope, I don't want any of you in me. So I'm going to close up my airway. I'm going to close up every orifice. We're just not doing this. You're not getting in. And which is weird because we wanted to get out, right? But your body just shuts down and says, no, we don't want it here. So you have coronary vasoconstriction. That worsens the cardiac conditions. So now we have even more hypoperfusion that occurs. And it just continues to get worse until epinephrine is given, okay? So our clinical symptoms of our anaphylaxis, of course, our skin system, hold on. I'm going to get this one. Skin symptoms are often the first indication. They'll be warm, flushed. You'll have that itching, which is called pruritus. Pruritus. Yeah, that's as much as you're going to get out of me tonight. And then you're also going to have vasodilation, capillary leaking of plasma. Christopher. Sorry, Jared. Area around the eyes are going to get pretty big. You may have some angioedema in the airway. You may have hands that swell, feet that get swollen. Respiratory systems are the respiratory system, their most chief complaint there is going to be that shortness of breath naturally, and tightness in the chest, stridor, maybe some hoarseness. And then, of course, our lower airways you can have bronchoconstriction there with wheezing and even crackles. Now, symptoms may be slow, may be more rapid. Sometimes or less than 3 minutes available to halt this life-threatening process is what it says. It's underlined and it's bolded for me in my notes. So cardiovascular symptoms are very serious complications of anaphylaxis. And some of those are going to be our decreased cardiac output. Remember, we have our widespread vasodilation, increased capillary permeability. And thank you, Christopher, for putting in about the leukotrienes, because those are the ones that they are very specific. So you have your histamine that does one thing and you have your leukotrienes that do another. So yes, please read that note that he put there. Blood volume moving from the intravascular space to the extravascular space can cause shock, of course. Obviously, we already talked about that because it's leaking. Body's only going to tolerate about 20% of blood volume moving anywhere. So you're going to have significant changes in vital signs. I don't know what the TEA is. I'll just take queen of everything. That's fine too. Increase heart and respiratory rate, decrease blood pressure. And then we're going to have GI symptoms, guys. That's even better. We have the nausea and the vomiting. You're going to have abdominal distension sometimes, profuse watery diarrhea. Because like I said, the body wants it out. They want it gone immediately. Deborah, we're using the advanced because we're doing both of them together. Okay, central nervous system, we're going to have that headache, dizziness, confusion, and anxiety. Remember when we went over many weeks ago about how when oxygen is deprived from the brain, the very first thing that you're going to see is anxiety. But when you also have widespread vasodilation, we have headaches. And then, of course, dizziness and confusion, anxiety can be caused from the leaky capillaries. And so all of this kind of moves in one space, right? Everybody sees where this is going. And then the sense of impending doom. These patients require rapid assessment and treatment, obviously. So go to table 24-4 and you'll see some signs and symptoms there. So let's talk about our patient assessment. Problem identification and intervention within seconds is absolutely crucial, and response to antigens may occur in a multi-step manner. So some can be acute, some can be delayed. So if you suspect that there's anaphylaxis, absolutely be super high on, or not high in suspicion, but high in, you're going to go ahead and treat this patient aggressively. That should have been the word I used. The responses, like I said, vary over time. So your acute reactions, that super rapid onset, those are the ones that are usually the most life-threatening. So that's going to be like the airway closing up. Delayed can be, the response usually isn't as exaggerated, but you can have symptoms up to 72 hours later. So keep that in mind. There is a biphasic response where the patient experiences that initial, and then they look like they're okay, but then they have the reoccurrence. And that's why there's up to 72 hours. So people that have allergic reactions like that, they really need to go to the hospital. Okay. Scene size up. Hey, what's the patient's environment? What is their recent activity? What's going on? Of course, we got to worry about scene safety. If they're being stung by a whole bunch of bees, I am deathly allergic to red wasp. And sorry about your bad luck. If you are using, or if you've been stung by a red wasp, I'll see you at the truck. My scene's not safe. I can't go get that person because I can't also be a patient, if that makes any sense to you guys. Absolutely big deal here. Never enter a scene where there's more than one person experiencing the same symptoms with a similar onset, because that could be indicative of something different. So determine our MOI, NOI, and never let your guard down. Severity of the problem will be indicated by the patient's presentation. Respiratory systems should be swiftly assessed. So go ahead and position an alert patient in a tripod position, leaning forward, because we want to get the best oxygenation possible with these people. And for unresponsive patients, assist ventilations using your bag mask device. Christopher is going to be the best guy in the world, and he's going to take over the last 18 slides of this. Joshua, we are doing AEMT and EMT at the same time. I don't know if I need to leave for you to share this, Chris, or how we want to do it. I can finish
I know
up
we had trouble last time.
I-
It was probably on my fault.
Don't say that. I couldn't find a class tonight. I tell you what, I'm going to do this. I'm going to mute myself.
You just make sure that if you can transfer it to me.
Let me see if I have that. I don't know that he ever gave that to me.
Oh, there it is. Hang on. Got it.
You got it?
Yeah. I'm gonna stop your sharing, and then I'm gonna share. So y'all hang on a second.
Thank you so much, Chris.
I
Appreciate it.
I got it. All right. Have a good night, Trisha. Bye-bye. Leave. No,
Thank you,
I'm kidding.
sir.
I don't want it to be ugly. Y'all, please
Bye.
understand. I'm sorry. All right. Make sure where I'm at. Did she finish this slide?
Start from the top.
All right. Good deal. Now, y'all know, y'all have heard me before. I try my best to be as productive as she is, but she's way better at me. I'll tell her that to her face. All right, on your patient assessment, we know that these patients are going to be challenging. They're going to have some of that acute anaphylaxis. They're going to have respiratory problems. Some of their reactions can be acute or delayed. Some acute reactions have a rapid onset and typically do result in most life-threatening situations. Some of their delay reactions may take longer or hours to manifest in the response, but is not usually life-threatening at the end and most of it. In some prolonged persistent reactions, anaphylaxis systems can last up to 72 hours. And a biphasic response, the patient experiences an initial reaction that appears to recover and then experiences a reoccurring of symptoms later on. Some patients who do experience an allergic reaction should be encouraged to seek medical attention to minimize these effects. This is where you're going to have your patients that will argue with you, that will fight with you, just because they're so used to it. They do this all the time. Sorry, we're going back and forth we have a boat on board and are out here with us, and we're getting some weather coming in, and we're fighting back and forth about preparing to get some medicine and all that stuff. I'm trying to handle that as much as we go too. Excuse me if I pause every now and then to go over things. All right, so our scene size up. What are we going to do? We know that we're going to start viewing our patients as soon as we start to walk into the door. And I say door as in or the setting we're going to be. Obviously, the most thing that's important to us is scene safety for myself and my partner. That is a big problem that we want to make sure we're thinking for. But so the respiratory problems are going to be sent to our dispatch. They're the ones that's going to tell us what's going on. We're the ones that's now stuck with trying to figure out what to do. So what do? We want to provide them with the oxygen. I always tell everybody oxygen's cheap. Give it to them. Let them have it. I don't care. Let's roll with it. We want to make sure. So determining their mechanism of injury or their nature of illness, we figured that out. We looked at them and, oh, they look like trash. So what are we going to do to fix them? The easiest thing we can do is, as an advance or as a paramedic, we can provide them with that epi. We can do some breathing treatments. They may be sucking down breathing treatments left and right, but one of the things that we're going to expect from those breathing treatments is what? What are we going to see change with them taking those breathing treatments? Does anybody know? High heart rate, correct. So we're expecting to see their pulse rate increase. You can notice some blood pressure change. I have a gentleman out here right now that is taking some breathing treatments. He has a pretty severe upper respiratory infection. His blood pressure will go up only a little bit as he's breathing, taking the treatments. And the reason why is, from what I think, is because he is concentrated so well on breathing, and we use the tubes out here. We don't use the nebulizer mask, so it's easier for them to put it in their mouth and go. But when he breathes so hard and trying to take such a deep breath, I actually do it just because it's interesting to me. I put him on the vitals and I check it and watch it go. So even though he's stable and I'm watching him at all times, like I have put some restrictions on him. He is not able to run the deck out here like he is doing all the time. I have limited him to certain work areas. He can't do a whole lot. He can walk the deck all he wants, but he's unable to climb the decks and everything like he's normally does. Deborah's saying she lost everyone. Everybody still hears me. There's no issues there.
Yeah, you good.
Okay. I thought so. But my screen. All right. Maybe it was just me. All right. Cool deal. All right. So as we're them, we're just gonna make sure we continue to monitor our patients. We're just gonna keep eyes on them and make sure that they stay healthy, that they stay going, that we just don't want them to. Lindsay made a good point, is he might vagal out. What when a patient does that is they bear down so hard and so much, trying to concentrate, trying to take those deep breaths, that they vagal down and their pressure changes and they pass out. That is the thing that we have to be careful for. Majority of that time is when somebody is using the restroom in a cardiac event and they do that. So that's something we have to be cautious for and make sure that we keep an eye on, because if they push too hard, they will vagal down and pass out. So severity of the problem will be indicated by their patient's presentation. Woo, got me. So we're going to look at them and they're going to have those different severities of trouble breathing. You're going to have that patient that struggles to breathe, but they're able to present with speaking ability. They'll be able to tell you what's going on, but they still will have some respiratory trouble. So obviously we're going to make sure that we start doing the airway evaluation. Their respiratory symptoms should be swiftly assessed. So listening to their lungs, that's one of the first things I want to do, is just because I want to listen to see what I have. I want to make sure that they're going to, do I have any rails? Do I have any wheezing? What part of the lung do I hear? Do I hear in the upper lobes, lower lobes? That's important to me. But you may start to hear them, I say it's like a drowning sound. You'll hear them struggle to breathe when it's in their lower lungs, because you know that's now fluid in their lungs. A noisy upper airway may be early signs of impending airway occlusion. I always ask my patients anytime during a respiratory issue if have they ever been intubated before? And those ones that sit there for a second and they take their deep breath and then they nod yes and no, up and down, and you're like, I'm sorry, I didn't want to know that question, because that now has changed it. When somebody does that to you and they tell you that they have been intubated before, be very cautious of them, because if they do it, they're going to crash pretty fast. And if they do, you got to think really fast on your feet. Sorry. All right. When we initiate that high flow O2, and they are the ones that have been intubated before, stay on top of listening to their respirations. Because if they're going to fail pretty fast. That's when you want to reach out and get your ALS response en route, maybe call for air support. It depends on your service. Be very on your toes. I really say don't turn your back onto them, because they're going to need your assistance ASAP. For unresponsive patients, for those with altered mental status who are in severe respiratory distress, assist them with their respirations using a back valve mask. Make sure that mask is also hooked up to a high flow O2. So if you have a secondary output in your unit, make sure you hook them up to that, so you're flowing enough oxygen and as fast as you can. You can use capno. I like CPAP too, but a lot of those that have the CPAP are not going to tolerate that on their face. Capno around the nose will let you know what their inspiration, expiration, and exactly what their capno is actually a whole nother section we could talk about, but I will limit that to very little bit. And if you already have them on the monitor, obviously, yes, we're going to be looking at their heart rate, be paying attention to what's going on. But if you don't have the capabilities as out there as the basics, make sure that you keep an idea on their respiratory rate. So keep their pulse rate. So keep palpating their radial pulses to see at least what they're going to. If we're at home and we have these and we're taking care of somebody, that may be the same thing. Just reach down there and check their pulse rates if we don't have a monitor or family member or something like that while we're waiting on a unit or whatever other means you're doing for family. So keep that in the back of your mind. Being basic life support measures if the patient goes unresponsive or pulseless. Assessment for a rapid pulse rate, pale, cooly, cyanotic, or red. Moist skin and delayed capillary refill may indicate some hypoperfusion. The treatment for shock includes administering some oxygen, place the patient in a supine position. I still would probably put this patient in a Trendelenburg position just because I know it is respiratory rate, it is respiratory driven, but I know that they're going into some source of shock. Even though we're going to do this, we want to make sure that they try not to lose any of the heat. So even though it may be summertime in the South and it's rocking at 150 degrees outside, make sure that you keep that patient warm, keep them going, provide that immediate transport, that high flow of diesel is being pushed. Assessment skills can be used to identify any potential for anaphylaxis, and they can take some aggressive actions to treat this particular patient. And if we're able to stop that anaphylactic process, if we notice that our patient has a respiratory distress or shock, treat those conditions as well during our transport. What's this say? Continue the assessment at the scene if the patient is calm and does not exhibit any of these symptoms. I will tell you, with respiratory distress or anaphylaxis, they can move so fast. I want to try to transport this patient as fast as I can. I want to make sure as I'm putting high flow on too, and I don't really give them an option. Like, what hospital do you want to go to this evening? Now, where I'm at locally in the Jackson, Mississippi area, we have several medical facilities that we can transport to. So that's one of those that we always ask is, what's their hospital of choice? Just for the reason of knowing what they want. Now, granted, it is our final decision on what hospital we go to. So if you know that you're 30 minutes out from one of the best facilities, you may try to push that. But if you know that you're like, man, this patient's turning south pretty fast, I need some extra resources, go to the closest facility. Nobody's ever going to challenge that. They may ask, hey, what would you come here for? My patient was going south and I needed some extra assistance. On your history taken, obviously we're going to investigate the chief complaint. But at this time, if the patient is not alone, then that will allow us to ask some other family members or some other people in the area or that what's going on, what has happened in the past. If they're unable to provide that information, we may have to prolong that. We may have to provoke that patient to give us the best answers that we can. But ask those yes or no questions, not very detailed questions so they can shake their head yes or no. Check if any interventions have already been completed. Recheck those as we're going through. If the patient's had one breathing treatment, as in a paramedic, I may turn around and give them a duo neb, where we'll use 2 different medications at one. Be alert for any statements regarding previous exposures. Maybe they've been out of the country or they come back. We used to worry a lot about the Middle Eastern COVID. That is very deathly. So if somebody's come back from the Middle East or in the east part of the world, ask those questions. Maybe they've been to a certain area that may has triggered this, or when they've come back, being in their home, coming back to certain things can trigger that also. Secondary assessment, anytime that we go en route to a facility and you've got time, you've already done your ABCs, you're pushing them along, start checking them, start going from head to toe, recheck them to see if there's anything that has caused potentially something that we've missed. We need to make sure that we oscillate for breath sounds continuously. Make sure you start inspecting their skin. Look for any sources of this reaction. You may notice a rapid spreading rash that can be concerning because it may indicate some systemic reaction to what's going on. And it's not going to be blotchy. You may have certain areas that is very red. I just came back from a cruise and and that's very honest because like I say out here, even though we are a very functioning small city, ultimately is what we are, we everybody's under everybody. So sinuses go around pretty well. We have a lot of respiratory issues out here, and we do get some normal, just weird craziness that I have to figure out. Like the other day, this guy come up and he had bites all over him. First thing I went to was bed bugs, but it wasn't. It actually was. He was having a reaction. He had mosquitoes and he was bit by some bugs that are outside while he was in the working area because he had his sleeves rolled up. I just had to start breaking it down. So the same part is we have to figure out some of these symptoms. Are they in respiratory distress, or is it respiratory stress because of something else has exacerbated his current problem? Our vital signs are going to help determine whether the body is compensating correctly or not. We're going to make sure that we have that baseline set of vitals, and that baseline is initially coming to them what we see as we enter the room. A rapid respiratory and pulse rate may indicate respiratory distress or systemic shock. Tachycardia and hypotension indicate systemic vascular collapse and shock. Monitoring devices used such as our cardiac monitor, our SpO2, finger probes, anything that will give us that diagnostic tool to make us treat them better. That's one of the things we have to look for. Factors such as a decreased circulation and exposure to carbon monoxide can alter some of your pulse oximetry readings. What is something else that will alter our pulse ox readings? Anybody know? Want to take a guess? How about all right? So Jared, what is something that will also alter our pulse ox readings?
Carbon monoxide.
Yes. What else? Bam, look at Lindsay's thing. Nail polish. Ladies, I can promise you, yes, I've had nail polish on. I have an 11-year-old little girl, 10-year-old little girl, sorry, and she likes to paint fingers, and I can't tell my little baby no. So nail polish will do it. Now, if we go also to check the old school way, we would squeeze the nail bed and look to see how fast it would turn white back to pink. That is not always the best sign when we are dealing with adults. Children, yes, that is one of the better things we can do that with them. But adults, it's a little sluggish, and it depends on how cold or warm that we are. So some end-tidal carbon dioxide levels are more reliable than pulse ox and low perfusion rates. The decision to administer oxygen to a patient experiencing an allergic reaction should basically be based on their pateness of their airway and breathing, not solely on a pulse ox reading. So if capillary refills on fingers, yes, that's right, Deborah. So what they're saying right there is just because we look at the pulse ox reading and it is in the low 90s and they are not having any visible trouble breathing, I'm not going to jump on putting them on oxygen. I'm just not going to do it. What if that patient is a runner? What if that patient is a swimmer? They're very fit. They have those abilities. They're going to have lower vital signs than somebody else. That's just because they have their conditioned their body for that particular reason. Let's see here. So reassessments. This is conducted typically en route to the receiving hospital. As always, we want to make sure we pay special attention. Should be given to signs of an airway compromise. Deterioration can be very rapid and fatal. They can be down in a second. Monitor a patient's anxiety and mental levels. Now, granted, we ain't always right. I'm saying mentally right. Really, what's a really baseline for all of us? At some point, we have to say, man, he just ain't right. That's maybe my normal baseline. So identify the severity of the reaction. Some mild reactions only may just require us to do some bedside treatments, some very calming mechanisms to try to help them slow their respiratory. Take slow, deep breaths the best that we can. In your nose, out your mouth. Just your calmness, your ability to try to slow them down is what we want to try to help on some of those mild ones. If we've given them any sort of medication as an epi, we want to make sure that we check that. Once we provide it, we want to make sure, is this working? Is everything going on? We want to make sure that their sorry, their condition has improved, or do we need to provide a second dose? We want to recheck all of our interventions. Is my IV still flowing fine? Is the oxygen improving their current system? And look for those changes in the patient's condition at such and such time. Okay, so at 1901, patients started improving. We noticed that their respiratory rate was not nearly as hard. We've basically got them calmed, and calming measures have succeeded and worked. So communication and documentation, when to med control and when to not. That all depends on your local protocols. If your local protocols say that you have to call on every anaphylactic reaction, every type to a certain point, if they get to 24 respirations a minute or they get at 16 or 14, make sure that you follow those. When we talk about documentation, remember your documentation is your lifeline. If you didn't if you didn't write it and you did it, you didn't do it. If you wrote it and didn't do it, you're in bigger trouble. So make sure that your report is very thorough. Make sure that you document your findings, your treatments, your improvements. You want to write your story of every single call. So make sure that when you're doing your report, it is very accurate and it is to the point of what's taking place. Let's see. So essential to differentiate between anaphylaxis or any type of other conditions with similar symptoms. People with allergic reactions are separated into two groups. The first group include patients who have signs of an allergic reaction but no signs of anaphylaxis. The second group, which includes patients with signs of anaphylaxis, do require 100% of oxygen at a high rate flow, epinephrine, and some antihistamines. What is an antihistamine that we have? Well, I have it at home. So, what is an antihistamine that we can also take at home if we know that our child or somebody's been stung by a bee and they have a reaction? What can we give them and can help? That is correct. Benadryl. Benadryl is one of those we give that also. Most of the time, we can give it by mouth. We can give it by IV. So those things they're great. That's what they're made for. Let's use it. That's the ability for us to have these skills. Whenever we notice them having dyspnea or certain types of signs of shock, we need to make sure that we do provide that epi. Obviously, we know we're going to see the heart rate increase a little bit, but those patients who start to appear to have some severe reactions, make sure that you provide a gee whiz, make sure you provide a prompt transport to the hospital. Remove that patient from the situation that's causing that. If they're in a field of flowers and they start having reaction, yeah, that's probably smart to remove them. The best thing we can do, it may be that. Obviously, we want to make sure that we give them enough high flow oxygen. So using the appropriate mask, the rate is very important. Maintain a high index suspicion for the potential for airway occlusion because of some swelling or edema. If necessary, treat that patient for shock by placing him or her into the position that was told by your protocol. Again, we like the Trendelenburg position. Maintain circulation by administering some isotonic solutions at a wide open rate. And that for your IV, it is not going to be TKO. It is going to be WAO, if you can pick up what I'm putting down. If there is no response from our patient, they are just not responding at all. Obviously, we need to call for some ALS backup. And we're going to begin our BLS maneuvers. We're going to make sure that we start at the basic level and move forward, trying to identify what has caused this problem. Make sure that your protocols are followed to where you may have to call med control specifically for that, or some agencies allow you to treat and transport and follow your offline med control, so you're able to provide medications and certain things as for your advances or higher. With your basics, you're probably going to be needing, once you realize that, you'll probably have to reach out and get some ALS assistance and notify med control for some assistance as you're going down the road. All right, so early administration of epi is going to be our biggest priority. If it's early and fast, I do the IM route fastest. Is the fastest route. Obviously, we're still going to try to work on that IV. But if once you go to provide that, giving it in a big fatty muscle like the thigh is the most approved area, you will notice some, if you use their deltoid or their shoulder area, you're going to notice some swelling in the skin because of the medicine is going to sit there underneath the skin, big ball, until it's rubbed. Anytime that I give an injection, doesn't matter from epi to decadron to whatever, I always like to add some extra force to that area. Like I'll put my palm on it and rub it for a couple of seconds to try to help release it into the body so it can take effect. Epinephrine can rapidly reverse the histamine. We know that, we've seen it. So getting that on board fast and early can help benefit that patient in the long run. So many patients do carry their own epinephrine, obviously in their EpiPens. We know that was a shortage a while back. Of them went to the vial of epi and having to draw it up and all that. So that was challenging during those times. If you come across a patient that has their own epinephrine pen, check with your provider and your med control, because you may have to get their permission to use theirs, just because it is not a medication that is giving to us to use. So that's the reason why we may have to reach out to them to get that. You can basically put it out there. Anytime that you go to give epi, it is a fast push. Shouldn't take you longer than 3 seconds to give that. Lindsay, that is correct. Epi for allergies, 1 to 1,000. We do have 2 doses of epi. You have 1 to 1,000, 1 to 10,000. Majority of the time, you're going to find those in the little glass vials, and the ampules. And then you have to make sure that you break the lid off that's already been scored. But I will promise you, I've done this before, that you can cut yourself with that. So be cautious of that. You may be required to give more than 1 injection, so be prepared. If you have it all in your bag or anything like that, you may pull out 2 at one time, stick 1 in your shirt pocket. Be careful and put it in your pants pocket, because you can break that ampule. Epinephrine may cause the patient's blood pressure to increase significantly, and there are some side effects of epi that you see on your screen. These side effects are worth the trade-off when it comes to epi used in that life-threatening situation. Some patients who do not exhibit signs of respiratory compromise or hypotension and do not meet the criteria of a diagnosis of anaphylaxis should not be given epi. We don't want to give it. I think it would help them if they're not meeting that criteria. We're giving a medication outside of our protocols, and that can cause a lot of issues. I'm not even going to say we need to provide rapid transport, because we know that. We know that they need to go. Lizzie, when you talk about nebulized epi, some services allow that. I have never worked for a service that allows that, so I've never done that. I know that it does work well. I've seen it done in a facility, but I have never. It's the same dosage. It's just going to be nebulized versus given an IM. I would believe that it's going to be faster than inhalation. That's just me. I've used it for croup mostly. Yeah. And there's other treatments that allow that to be used. I am fully for it. It's one of those that hey man, if you told me that Decadron can feed your athlete's foot, I was like, man, that's great. I'm gonna think about it next time. That's cool. Maybe I can see why it does that. I have no issues, but I do know that they do give it for some respiratories, but a straight IM is gonna work the fastest that it can. What's here on my notes? As many as 20% of our patients do have a reoccurrence of symptoms within an 8-hour period, even if they have been symptom free for up to that timeline. So just remember, it's going to be a med control call, but if you treat the patient on scene and they refuse transport, that's one of those things that you need to remind to, and the med control is like, yeah, okay, or no, they really need to come to the facility. I would lots rather transport every single patient I come across versus doing a refusal. It is so much easier just to transport them because in the end, the monkey's off your back. Now it's on the facility. You did your job, you transported them. But the refusals after treatment is the worst because most of the time you will be back because of that same exact issue. Let's see here. Obviously, insect stings and an allergy. It produces about 90 to 100 deaths a year from the insect stings. What's that say? The stinging organ of most bees, wasps, and hornets is a small hollow spine projecting from their abdomen, and those little suckers love to leave them behind. So that may be something too that you may have to help remove that stinger, either by tweezers or by a flat card or ID or some point like that. So just be mindful of that when you're doing your assessment that you're going to be looking potentially for a stinger. We've all had these ant bites. Maybe not like that, but I've had them multiple times on my arms and my legs and stuff like that. So be cautious of that. Some ants, especially the fire ants, strike repeatedly. Those little suckers, they got to put out more hormones to attract those other ones than anything else because they don't fight alone. They bring their friends, and I don't like them or their friends. Look for that. And those bites on his feet can also be triggered with what's going on. Deborah says, yes, tobacco does help. It may not be medically approved for you to come in and have some snuff underneath your bandage holding it down. But yes, it does work. A fresh, moistened dip, or you have even seen people use cigarette. It does work. It helps. I have never used meat tenderizer. I'm not doubting you at all. That's a great idea. I don't know. Think about that. So I'm not going to tell you not to use the tobacco, but be prepared for some of your facilities to be like, well, what is this? And why do you have tobacco on there? Those are more of your home remedies. So be cautious of using those home remedies because sometimes it may be used for you to step out on your own and cause more issues. We've all seen bites like this. We know that a majority of the time from our wonderful pterodactyl mosquitoes that we have down here in the South, it will whelp up. The itching's there. Y'all have even heard taking your fingernail and putting an X over the bite can help keep that from itching. I do it every time. I swear it don't work. I don't know. I try not to scratch them. You will see them constantly scratching that redness. Had a gentleman out here with us now. Eventually, initially, he came to me, he said, I got a bump on my neck, man. I can't see it. Can you look at it? And I'm like, man, I don't want to look at your zit. But it turned out to be a boil. I did draw lines around it to make sure that it wasn't swelling. I did not think that it was like a spider bite or anything of that nature, but I wanted to help give me a baseline of what it was when I saw it versus what it will be the next morning. And I told him, I said, look, just don't wash this area tonight. I need you to wipe it with a clean cloth or something like that. So I write with the Sharpie pens. That's the only ones. I'm bougie when it comes to that. So I prefer writing with those pens, and it is harder to get off. But using that Sharpie, or you can use a fat tip, it doesn't really matter as long as you know what you're looking at. And if you do it while you're transporting, you don't have to make this big art piece on their arms, but just make some dotted lines as you go around. Just where it started at and where it's swelling, and that will also give your facility some idea of how much of swelling has occurred. We talked about this a while ago about removing the stinger, so I'm not going to sit at that much. I'm not going to go over that one much. Patient education is something that we don't do a lot, and that is into every aspect, and even into law enforcement. When I was in the law enforcement world, we don't educate the people on why the laws are laws and what they're there for. I don't agree to every single law, but they're there for particular reasons. So I am a huge advocate for doing patient education. Once I know that I have this patient taken care of and everything's okay and on the good route, I love to teach. I love for education. I am a big proponent of it. Letting the patient understand more about what's going on, what has caused it, and what can we do to prevent that is amazing. Just think, I know we're using them for the CPR dummy, but let's teach them why this is going on. Don't try to be over smart than what we are. And the reason why is they may know more than we about the particular situation going on. They just aren't able to tell us. Do some good patient bedside education as you're transporting. But I like to say, still use the KISS method. Keep it simple, stupid. I'm not trying to talk over their head, and I'm not trying to make them feel stupid, but let's educate them while we're going. There's a lot of things that we can, number one, avoid the antigen. Bruh, how do you tell somebody to avoid ants? Them little sap suckers are everywhere. What you want me to do? Walk around in a bubble? And then you have these people that are allergic to everything. We have one guy here, literally, everybody looks at him every morning. If his face is all swollen up, you just take it as it is and you keep going. You're just like, good morning, man. That's normal for him. If he comes to me later on and half of his face is swollen, the other half has gone down, I'm like, hey, man, what can I do for you? He's very educated, but he is allergic to freaking everything. I think he's allergic to himself. So trying to tell somebody how to avoid those antigens, you can't. It's really hard to do that. It is very beneficial for these ID tags to wear them, have those bracelets on. I'll straight up tell you, I am highly allergic to penicillin and codeine. I don't wear those. I don't. That is majority of the antibiotic that they give is penicillin. I am allergic to penicillin and any derivative of penicillin. Everybody knows that that my family. I swear I've even thought about tattooing it on me, but penicillin makes me quit breathing. So not a good thing. I'm addicted to that. And if the patients have those anaphylactic, they have those EpiPens on them, let them know that they can use it. Don't be scared of it. Use it. That's what it's for. Keep those EpiPens, educate them when it's good to give it, when it's not good to give it, and then tell them, hey, you're gonna be sore. You're gonna probably have a bruise on you tomorrow from using this EpiPen. Here's why. No, it doesn't shoot out at 100 miles an hour. But when you tell somebody, hey, this is like an airbag going off in your car. When you put this on your leg and you push that button, it is firing so fast and releasing medicine so quickly that it's bruising the skin. It is bruising the tissues. It's down to the epidermis. It's bruising everything. There's one little bitty hole that it comes out of. So that's what happens on everything. Sorry, I was listening to the radio. And just let them know. I know when my mom used to tap, she would quit breathing if she could smell seafood. She would give it several times that I can remember through her time being around. She would always bruise and swell, and it was horrible. So that's part of the education there. For everybody, this is the end of the class. The ones watching online, there's our code that we're going to use for the class. Does anybody have any questions, concerns? Let's talk about this. Do we have something that we want to address, bring up that maybe Patricia spoke about and or myself We'll leave it open for the groups. I see our fearless leader is back in the room. If anybody has any questions, I'd like to address those.
Where are we supposed to put that code in? Because I tried for the other class recording and I couldn't find it.
So I'll take that one, Chris, just because it's still in flux. So for now, just email them to me. I'm keeping track of them that way. That way it's still in writing and everything. We are going to be re-adding a form, an attendance form to the new website. It's just not there yet. In the next day or two, it will be. It'll probably be inside the SharePoint. I heard her. I'm about to do that now. I was just actually getting in to let y'all know that link you used earlier that wound up sending people to a different room, it's fixed. If you're going to go into SharePoint and click the virtual classroom at the top left, you can do that now. That's fine.
I have a question.
Go ahead.
For our classes, I've been copying off of the basic book. I've been like copying from someone else's basic book. Should I copy from an advanced book to make it easier to follow along?
So basically a lot of the same, it's the same material with the adding of the epi, the dosages,
Right.
the routes. So you're going to see some of the same similar information as our advances are. It's just our advances are going to be more in drug related. So that's
Right. And
why
I can't give epi 1 to 10,000 or 1 to 1,000 because I'm becoming a basic, not an advanced or paramedic. I get that. Also, is there a list of names that I could put my name on for when I have questions or need help that I can contact someone in our classroom besides going to Rob, you, or Patricia for just simple basic questions?
So I'll say, if y'all want, you're welcome to post questions into the Teams chat at any point. And advanced students, if y'all know an answer and you're willing to help, like Lindsay Walker is fantastic. She's wanting to become an instructor with us anyway for the basic stuff.
Yes.
My whole plan with combining y'all like this was to get you to talk to each other more. That way you have study groups, you have people that can help you out. By all means, you don't necessarily have to come to us for every question. If another student knows the answer, then great, because you're also testing their own knowledge as well. It benefits them to help you out.
Okay, so how do I get to the team if I'm not in the class? How do I get outside to the team chat for them to see?
So
Because for some reason on my computer, my tablet that I'm on now that I use all the time, everything was so different. I don't know why.
So yeah, they revamped the way Teams looks, and actually to the point where they didn't just make a new edition; they made a whole new Teams program.
Okay, so I
Microsoft
was
did.
like,
So
I was panicking.
yeah, no, they updated it recently, and they gave it a big
Okay.
facelift. But that being said, if y'all want to access these chats outside of a classroom, all you have to do is just open up Teams itself. Don't go through the ARES website. Just actually open up the program Teams and log in, and you're going to see the team that we're in. You can click on EMS Academy or whatever, and you're going to see all this chat that happens in every class. It's all going to be there. And so you can scroll up and see what conversations happened a week ago or a month ago or whatever, and y'all can actually continue to talk. We also have the Discord. Our Discord server is not class related. It's public safety in general. But same thing, you're going to find other instructors, other providers from different areas. Maybe they're not ARES students, but they can still help you. All that is still there. So I do recommend use those resources. They only help.
Okay. And then
for the ones that can't see the chat, I don't know if anybody can't. Lindsay's, I'm not pawning off. I'm not trying to pimp Lindsay out, but she is a great resource. I will say it to her face and behind her back, y'all. She's very good. She's very knowledgeable. I wouldn't say this if we didn't believe in her. So she has put her number in the chat for anybody that would like to speak with her. I really don't want to give it out for the ones that can't. So if you guys want it and you can't see the chat, please feel free to email me. I'll be more than happy to provide that by email if she's okay with that. But you can always email Rob or I or even Patricia, but understand that we got a lot of things going on in our own. We may not be able to answer that Teams as fast as we should, but please understand that we would be glad to help you. You can also set up through our website. We've, like Rob has said before, There's some extra, you can set up some tutoring. You can go in there and schedule the tutoring and pick out who you like to tutor with and all that. So that is part of it too. So you guys you can use that resources also as using Teams. And just know that Rob, Patricia, and I, anytime y'all start a chat or y'all talk back and forth and it's a group one, we do get those messages. So we may chime in if we have a second and maybe somebody hasn't answered you fast enough. We will answer you. It's just may not be as a fast as it need to be. So please excuse that on the front end.
I appreciate that because sometimes I feel like I'm lost over here because I have no one else to, and I don't want to bother y'all, but then I have no one else to ask questions to or get another opinion of because I don't have nobody's info. And I'm not sure all of this has changed. So I did not know where to go.
Yeah, our website got a facelift. Now, that being said, if anybody hasn't seen how to do it, to get to the SharePoint, if you're at the ARES website, click on the little hamburger at the top right with the three
See,
red
I didn't
lines.
have a hamburger, so I had no idea what you was talking about.
That's how you pull up the main menu.
But there was no hamburger there.
Oh, that may just be an issue with your device that you were accessing it from. But if you click on that, it brings up the menu, and then it's just a direct link that says Student Dashboard. Click on that.
I seen the student dashboard, but I didn't have a hamburger, so I was like, "Oh, maybe this is what he's talking about, student dashboard," and that's what I clicked on.
Yep.
Now, I don't know about my email address, why it's not working and why I'm not getting responses back. I don't know. I'm getting ready to send another one out from my personal email to you, CC Patricia, and stuff like that. I might have sent it late last night because I was up till 3 o'clock. Actually, I took this test. I took this test and I took module 3 test. Let me ask you something real quick. I did the module 3 test. I did all of the answers except for 3, but then it gave me a score of a 90 something. Does that score count or did I fail it because I didn't complete all but 3 questions?
If it gave you a score, it's whatever your score is. The system does it on its own.
Okay, so my score is okay. So my score is good. Okay. I just was trying to figure out because I know it cut off, but I still had 3 questions left. But then it gave me a score. And then I was like, okay, does that mean I failed it? Because I can't look at it again because I usually copy my score so that I can keep track of my grades. And it's not there for me to copy to keep track of. So I'm thinking that I just failed it.
No, you're good.
Okay. And I didn't mean to go ahead, but since while I was having downtime from work, I've been trying to go ahead and catch up. Read the chapters while I'm sitting in the ambulance and I'm not driving, or vice versa, or we on the wall waiting for a patient to go in the room. I have my book with me, my papers that I printed, and I'm just reading up on it. And I hope it's okay if I just go ahead and take those tests.
I'm gonna leave that up to your instructors.
I've asked, but I've not gotten any questions back yet, any response back yet. But I'm gonna send out another email of what I haven't tested on because I was either out of town, working, and sick because they thought I had the norovirus because I just came off of a cruise, but I didn't. So I'll email all of y'all back that, and I don't know what to do from there.
That's fine. We'll take care of it offline. I wouldn't keep holding up the class and everything
Okay.
further right
All
now.
right.
Anybody else? All right, for the 16 of y'all, besides Rob and I, go ahead, Lindsay. I see you unmuted.
Just real quick, I sent you and I sent Robert an email.
Yes, what I responded to you earlier.
Oh, did you send me another response back?
No, as you can tell, I was a little late, but I'll work on that in a little bit.
You're amazing. I appreciate it.